Good morning, everyone. At the very outset, I would like to say thanks to Dr. Santosh Anawar, who has given me this opportunity. And with regards to the dais, dignitaries at the dais, madam, I start with the age-related macular degeneration. What are the key points? So we all know that ARMD, it leads on to central visual impairment with the abnormalities of the RPE and Brooks membrane. There is a CNVM formation. There are focal areas of RPE loss, and subretinal sub-RPE hemorrhage or serous fluid or subretinal fibrosis is the sequelae of this ARMD. In this picture, we can see that drusen, which is the early dry ARMD, is seen in early ARMD cases as a sub-RPE collection, and photoreceptors loss and severe vision loss with fluid accommodation occurs in ARMD in advanced stages. Symptoms are the decreased visual acuity, insidious, or it is sudden in onset, blurred vision, distorted near vision, positive scotomas, visual distortion, metamorphopsia, micropsia, and sometimes vague visual complaints are there. Dry ARMD usually does not cause severe vision loss. However, wet ARMD is the major cause of severe vision loss. There are various risk factors. There are modifiable risk factors like cigarette smoking, sunlight exposure, serious diseases, hypertension, obesity, hypercholesterolemias. Cigarette smoking is very, very important in this modifiable risk factors. And there are non-modifiable risk factors as well. So ARMD, it can be non-exudative, it could be exudative, it can be geographic atrophy, or it can be CNVM or this dry ARMD, geographical atrophy, it's an advanced form of dry ARMD, typically begins in the parafoveal area and it increases in the circumferential pattern. Geographical atrophy is a well-defined circular area of size more than 175 micrometers. Progressive loss of areas of RPE, photoreceptors, and underlying choriocapillaries, they occur. On OCT, absence of the RPE, inner segment ellipsoid zone, external limiting membrane, and outer nuclear layer occurs. So what are the different types of CNVMs? Type 1 is the occult CNVM that occurs beneath the RPE. Second is the classic CNVM. It is above the RPE. It is also called as type 2 CNV. Type 3 is the retinal arterial proliferation. Anastomosis occurs between retinal and choroidal vessels, also called as aneurysmal or PCV, polypoidal choroidal vasculopathies. According to the position, it can be subfoveal, juxtafoveal, extrafoveal, or peripapillary. So this is the first CNV type 1. You can see in the diagram. It is the sub-RPE lesion which is occurring. Type 2, it is above the RPE. And this is the CNV type 3. We can see a lot of distortion is there in the layers. There is schisis also. There is sub-RPE collection and proliferation. Choroid is also not normal here. You can see. So aneurysmal CNVM or the PCV, it is a spectrum of conditions characterized by pachychoroid in which disturbance in choroidal circulation occurs. PCV presents a serosanguinous maculopathy. Generally, a patient presents with sudden loss of vision or scotoma, and once you do an indirect ophthalmoscopy or plus 78D examination on slit lamp, what you see is a serosanguinous. So there is collection of hemorrhage there with sub-elevation in the foveal area. So on FA, in the late phases, it shows intense localized area of hyperfluorescence. On early ICGA, polyp-like lesions are seen. So a combination of anti-VEGFs and vertiporphin PDT, they are commonly used in such cases of PCV. So we can see polyp formation here in case of PCV. There is a dome-shaped PEDs there. Hyperreflective dots can be seen. Very important is to see that the whole retina, it is lifted up. It is lifted up and you can see that RP elevations are there. There are very high PEDs are there. Tenting is there. They are also called as finger. Impressions are there like fingers. So this is PCV, but the upper layers are nearly normal with few hyperreflective dots. This is very significant in this. Another picture of the same lesion, PCV. So diagnosis, it is based on Amsler grid, Snellen's chart acuity, slit lamp biomicroscopy, fundus fluorescein angiography, ICG, OCT, and OCT angiography. We can see that in fluorescein angiography, we don't see the occult lesions as good as we can see in the ICGA. You can see the hyper intense lesions on OCTA. So how do we differentiate between classic CNVM from occult one? So classic CNVM, it is a rapid and early filling of dye is there. However, in occult CNVM, slow and late filling is there. Classic CNVM is bright filling of dye. Less intense filling of dye is seen in occult CNVMs. Lacy patterns are seen in classic CNVMs, and stippled hyperfluorescence is seen in fibrovascular PEDs. Also, they are described as classic. It can be predominantly classic CNVM when it occupies 50% of the lesion. It is called as minimally classic CNVM when it occupies less than 50% of the lesion. Occult with no classic CNVM has a 0% component of classic CNVM. So fluid is an important part. We always know that if there is fluid, we have to inject anti-VEGFs. Or there can be disciform scar where we know even if anti-VEGFs are given, we are not going to get good vision. This is important. Occult versus classic CNVM. We know that type 1, it is seen in ARMD or polypoidal choroidal vasculopathy or CSCR, whereas classic or the type 2 is seen in ARMD, myopic CNVMs, inflammatory CNVMs, angioid streaks, and choroidal osteomas. Type 1 CNVMs, they progress slow and respond slow. Type 2 CNVMs, they progress fast and resolve fast. So how do we treat dry ARMD? It's not, we always give some antioxidants in the form of zinc oxide, copper, vitamin C, E, lutein. AREDS 1 and AREDS 2 study are there for it. However, most important is to give anti-VEGFs when there is a wet ARMD, when there is fluid is there or distortion because of the CNVM or the wet ARMD. So Macugen, Avastin, ranibizumab, aflibercept, brolucimab, they have come. Now there is faricimab also. So brolucimab we know is a low molecular weight VEGF antagonist, and it is found to be non-inferior to aflibercept with every 12-week dosing. That is important. And with faricimab, it is the 16 weeks dosing. So all the more important. It has been approved for use in US in early 2022. So there are various important trials associated with wet AMD. We should know that anchor studies there where it was concluded that ranibizumab, it provided greater clinical benefit than verteporfin. Marina studies there, PIRE, where ranibizumab is inferior to monthly injection, then view 1 and view 2. Pro-Renata treatment, PRN treatment is there. Here it is, the patient is followed up on a monthly interval and treatment is done based on visual acuity and SD-OCT. Then there is a Pieronto study where the conclusion is that comparable visual outcomes from phase 3 clinical studies, but only fewer intravitreal injections were required in this study. Harbor study, CAT study, and then treat and extend protocol, which is very much followed nowadays. So TREX is another variable dosing regimen. The advantage is reduces the number of visits for patients to the clinic and thus improves patients' compliance. Disadvantage is that the regimen may result in unnecessary overtreatment of patients, and it has been reported that long-term use of anti-VEGF injections, they might result in geographic atrophy in TREX treatment. Other treatment modalities are laser photocoagulation for fovea-sparing CNV lesions. It can be PDT, or it can be submacular surgery for patients with wet ARMD. Macular translocation surgery and mechanical displacement of subretinal hemorrhage with gas can be made. Pneumatic displacement of submacular hemorrhage using intravitreal gases or a gas injection with face down positioning is also done. Radiation therapy is also considered in CNV in wet ARMD. We have to do OCT and see ourselves, not very much dependent on the technicians, because sometimes it is mislabeled. You can see that the NSD is visible here on this side. This is the NSD seen, and one can, if you don't do it properly, if you don't do OCT properly, you can miss that macular hole, and injection is given unnecessarily for this surgical treatment. So conclusion, it's a diagnosis of ARMD is vital. Always try to find the cause of CNVM. Avoid unnecessary injections. Check the vials and note the details. Correct technique should be learned, and asepsis is mandatory. Thank you.
Thank you, Dr. Manisha. It's a very nice presentation, and you finished